Okay, I think we'll start up without any further delay. Okay, so welcome once again to the SKIP session 5. Okay, today we have an eminent speaker today, Dr. Jojo Kotur, okay, who is the professor in the Department of Conservative Dentistry and Endodontics at Royal Dental College in Palakkad. So today's topic basically is on endodontics now and back in old days. Okay. So this is the first topic on endodontics as far as SKIP program is concerned. We have third years and final year part 1 students. So first of all, let me welcome our speaker of the day, Dr. Jojo Kotur, to this exciting SKIP session. It is a great pleasure to have you on our platform. Okay, especially you are a person who has your own institute on root canal point, which is giving training to a lot of BDS and MDS students about endodontics and about aesthetics. Unfortunately, my wife Mini also had an opportunity to get trained in your institute on microscope, which was really good. And because of that, many of the retreatment cases currently are being done under the microscope in my clinic itself. So it is really good. So I wholeheartedly welcome you, Dr. Jojo Kotu, to our SKIP session. Next, I welcome my colleague, Dr. Reno, who has been very much instrumental in the organization of a SKIP program. Wholeheartedly welcome you, Dr. Reno. I also welcome our coordinator, student coordinator, Steffi Sargent, the final year part 1 student, who's been coordinating this program with the Department of Public Health Dentistry. Welcome, Steffi. And my dear students, third years and final year part 1 students, I wholeheartedly welcome you to this exciting session. Okay. Now I hand over the mic to Steffi. You can introduce the speaker.
Thank you, sir. It is my great pleasure to have Dr. Jojo Kotur as our speaker today. He completed his dentistry in the year 2006 from Dr. MGR Medical University, Chennai, and completed his MDS by specializing in conservative dentistry and endodontics in 2011 from Meenakshi Ammal Dental College, Meenakshi University, Chennai. He was bestowed with various laurels during his master's training, which included Best Case Report for the year 2009 and 2010, Best Postgraduate Student, and the University Silver Medalist for 2011. He also received a Special Appreciation Award from the Indian Endodontic Society in 2011. He has many pioneering firsts to his name. He's foremost to report in literature on 4 canals in maxillary lateral incisor, 7 canals in mandibular central molar, second molar, and many more. And added to these first, Dr. Kotur has additionally contributed to endodontic literature by contributing 24 publications in PubMed's indexed international journals and various other publications. He's also made valued contributions to textbooks in his specialty and acknowledged as a contributor in Grossman's endodontic practice in the 12th and 13th edition. Dr. Kotur is actively involved in teaching undergraduate and postgraduate students for the past 5 years. He's currently academically affiliated to Mabislius Dental College, Kodamangalam, Kochi, as a reader. Welcoming you, sir, to our SKIP session.
Thank you, Benley, for organizing such a wonderful event. Also thanking Steffi for the introduction. There is a small correction. Right now, I am associated with Royal Dental College.
Yeah. Probably that she's taken it from the website.
No problem. Anyway, I always cherish the moment which I had spent with Mahabesir Dental College. So anytime you can tell I'm a staff over there also, not a problem. So we will start the presentation.
Yes, Dr. Jojo, you have made the host, so you can start the presentation.
Is the screen visible?
Yes, it's visible. Yeah.
Okay. So I understood the audience is basically third years and finally a part A. I'm not going too much theoretically about the subject which I'm going to speak. I'm going to make it very brief and clinically interesting as possible for you. I will start with the endodontics, what was practiced long back. Then I will speak a little bit about the current status of endodontics, and maybe we will try to understand where else endodontics have to improve at this point of time. So if you look into certain IOPA, I hope everyone can interpret at least an IOPA. Here you can see a root canal treated tooth. Here also you can see a root canal treated molar. This one is an old silver filling. You can see this silver filling, and this is a gutta perca. So if you look very carefully about the endodontic aspect of these root canal treated teeth, you can see it is not something that we had learned in the theory. The GP is only halfway here. The silver point is also only halfway here, and the GP which is placed is also halfway here. But this particular X-ray, that is a premolar X-ray, this root canal was done almost 18 years back. And this molar root canal was done 22 years back. So if you look into theory, if you want to have a successful root canal, you have to clean and fill the root canal to the apex here. And this, you have 2 roots or probably 2 or 3 canals, you have to reach here. But what happened here? And cases like this, we generally used to get in our clinical practice. That is, it will be totally against what we had learned. It is short of apex. There is a lot of voids, no post-endodontic filling, but the patient will be asymptomatic and there is no periapical lesion. So what could be the reason for this? I would say the reason for this is purely luck. And I can enumerate certain other reasons other than luck, like the exuberant consumption of antibiotics by the Indian population, or I would say the amazing ability of the body to tolerate the mistakes that is done by us. But basically, don't think that when you perform a root canal like what you had seen in the previous slide, you will get success. That is not going to happen. If you do 100 root canals, probably 10 will not create any issue, and you can expect it to be asymptomatic like what we had seen in the previous slide, and that is what we call it as luck. According to me, there are 3 problems with the luck. Luck is not teachable. You cannot teach how you have done it. Secondly, luck is not something that is repeatable. That sometimes you may be successful, but if someone asks you to do it again, you won't be able to do that. So luck is not something that is repeatable. The third is the luck is not predictable. You cannot guarantee that once you are done a procedure, you can't guarantee the patient, yeah, this will be successful. So that's the 3 major drawback of luck. So that is, I'm not saying in olden days, root canals used to be practiced like this, no. But in olden days also, dentists used to do amazing root canals, but there are many drawbacks at that point of time. So what happens in reality when you do root canal treatment like this, that is short of apex, is probably after 2-3 years, you get huge periapical lesion like this. So this is what you can expect if you do a bad root canal treatment. So when you look into the 80s or probably 90s, what we used to do in endodontics is, if you have a fractured file, if you have a ledge or perforation, you do extraction. But what we are doing right now is we are trying everything from separated instrument removal, perforation repair, restoring non-restorable teeth, microdentistry, micro-isolation. So we are trying everything to save the tooth right now. So that's a big difference between the dentistry or endodontics in particular, what was practiced long back in 80s and 90s, and currently what we practice right now. So what had improved from 80s to 2000? I would say we had improved in all aspects of endodontics, except few which we will discuss at the last part of the presentation. Number one, we improved in case selection. Previously, when a patient comes to you with tooth pain and you identify there is a big decay involving the pulp, we generally jump into root canal treatment. But right now, we believe that it is not about doing root canal treatment, but we need to look at the perio, endo, and restorative aspect of the tooth before you jump into a root canal treatment. So that is something which I would like to insist to all the students who are watching this presentation. Do not jump into endodontic directly. Rather, try to examine that particular tooth periodontally, also restoratively, because there is no point in doing a root canal on a tooth which is not restorable. The next thing which that had a big change from 80s to 2000 is we dentists would like to assess our own capability before jumping into procedure. You know, in 80s and 90s, dentistry is all about extraction and amalgam filling, or probably removal partial denture. But right now we have around 8 or more specialty, and you need to learn 3 years for each specialty. So we had advanced a lot, and don't think that everything can be done by a single person, like dentists used to practice in 70s and 80s. So you need to ask this question to yourself about the capability from your side before jumping into procedure. I would say this is also a big change that had happened right now in endodontics. We generally doesn't recommend to take up all cases that is coming to you, but rather identify the case which is good for you, and the difficult one, you give it to a specialist. That's how we should practice in the modern era. Secondly, the change what had happened in endo is preserving tooth vitality. When I was a third year student, I thought endodontics is all about root canal treatment, and it's all about killing tooth or teeth. But modern endodontics is not about root canal treatment. It is all about preserving tooth vitality. So this change in trend happened recently, I would say after 2010. If you look into this X-ray, you can see a red lucency involving the pulp, approximating the pulp. I won't say involving the pulp. There's hardly any periapical change. Patient is showing signs of reversible pulpitis. See, we always try to preserve the vitality of the tooth rather than jumping into endodontic procedure. So here you can see the decay. I removed all the decay. You can see I hadn't exposed the pulp, and we had done a pulp capping here. And this procedure is called DME. I don't know whether you will understand it, but I want you to look at the final image, and this one is the final X-ray. So you can see the restoration is very close to the pulp, and this one I had restored with an overlay. Overlay means it's a ceramic overlay which replaces the missing part of the tooth. So here, this is again a big change in endodontics. Previously, this tooth definitely will go for a root canal treatment or probably a crown after the treatment. And modern endodontics is all about tooth preservation and trying to minimize the tooth damage, also the vitality of the tooth. Second, the third is obviously I had mentioned is about tooth conservation. So even if you're doing root canal treatment, we do the access cavity as minimal as possible. You can see the access which I had created here. If you put a rubber stopper, you won't be able to see the access cavity. So the access is that small. And I had done the filling and the post and the post radiograph after the root canal treatment. So you can see the access is very small. So I'll try to make it as small as possible to make tooth conservation a reality. So that's also something that modern endodontics is dealing with right now, that is tooth conservation. The fourth is the restoring non-restorable tooth. Previously, if you have a tooth like this, the X-ray is here and the clinical picture is here, definitely it have to go for extraction. But again, modern restorative dentistry and endodontics had improved a lot in addition. Its biomechanical principles and the isolation. So if you can do a good isolation like this, you can build the tooth, and this tooth definitely is going to survive maybe a decade or more. I can guarantee that. This patient I had done around 6 years back, and it's still surviving. Why I'm saying this, the patient is a dentist. So that's why I have a good follow-up of this patient. The fifth improvement, what happened is in isolation. You know, in olden days, we don't do the rubber dam isolation, even though it was invented by S.C. Burnham in 1886. It's almost 150 years back, S.C. Burnham or Stanford Christine Burnham introduced rubber dam, but we generally don't use it at this part of the world. I'm a big fan of isolation. I do all the procedures, including restorative dentistry and endodontics under isolation. So this is something that we have to learn if you want to do good dentistry. Unfortunately, I don't know whether the undergraduate curriculum is yet to implement rubber dam isolation in your practice, in your clinical curriculum. So I would highly recommend, if you have a chance, to learn about rubber dam and start using rubber dam in your practice. And that is something that will help you to do a better work in terms of restorative dentistry and endodontics. The sixth improvement happens in root canal anatomy. So this is a picture that was taken from the 8th edition Grossman. And if you take root canal anatomy chapter, a mandibular molar is designated like this. That is 2 roots, 2 straight canals. If you happen to see a picture like this, everyone would think root canal is very easy. But if you look into the recent edition Grossman, which is the 13th or 14th edition Grossman, the same chapter, the same mandibular molar is designated like this. Now, seeing this picture, you will understand how complex is actually the root canal treatment. It's not easy as we thought back in old days. So update your knowledge. That is something that helps you to do a better work. In addition, we have quite a good knowledge about other aspects or other factors which influence the root canal treatment, which involves the anatomy of the tooth. We have advanced studies in micro-CT and CBCT, which help us to identify the lateral canal, apical delta, isthmus, curvatures, development anomalies, dentinotubules. All these things also have a huge impact on the treatment outcome. So modern endodontics, again, have deals a lot about these sub-factors, or I would say gives more importance to these sub-factors to give a predictable treatment outcome. The 7th is on irrigation. I would say back in old days, we used to do only syringe irrigation, but modern endodontics understood that irrespective of the file system, whether it is hand file or the rotary file, I don't know whether you have seen rotary file, it is connected to a machine and it rotates, and that's how you perform root canal. You can see these are root canal micro-CT images. What is marked in red is the area where the rotary files are touched, and what is marked as green is the area where the rotary files hadn't touched. So with the advancement in the micro-CT, modern endodontics understood that the rotary file is not going to touch 100% of root canal system. But here comes the importance of irrigation. So we have to do a lot of irrigation, a lot of irrigant activation in order to reach the irrigants into these imperfections of root canal. And that's how modern endodontics believe more in irrigation rather than shaping with rotary or the hand files. So this is a post-op radiograph of a root canal treatment done by me. You can see the lot of lateral canals towards the apex of the root. You can see it here and here. Don't think I have taken a file and instrumented these canals. No one is going to be able to do that. How these lateral canals or delta has been filled is primarily because of the irrigation regime which I have used in my clinical practice. The 8th is the post-endodontic filling. There's a lot of improvement happened in post-endodontic filling. Previously, we used to do post-endodontic filling with amalgam. I'm not saying we should not give amalgam. You can give amalgam, but modern restorative dentistry uses composite for post-endodontic filling. I would say bonded restoration. So it's very important you clean the pulp chamber very well like this before going for any adhesive procedures. It's not amalgam. So if you are going for amalgam, you don't need to clean the chamber like this. It is not going to bond. It stays by retention. But when you're giving an adhesive restoration, GIC or composite, you have to make sure that you have a very clean pulp chamber before you bond. The ninth improvement happens in magnification. You know, in 80s, we don't use loops quite often, at least at this part of the world. But I would say in 90s and early 2000, loops had came into practice. So this is, you can see myself practicing with a loop, and here I'm using a microscope. So what does the magnification does is it makes things more visible. So if things are very much visible, or if you have a greater vision, definitely you can do good work, because it will improve our efficiency of the procedures that we do. So one of the major advancements that happened in endodontics is the magnification. From no magnification, we moved to loop, and from loop to microscope. That's what the current trend on endodontics at this point of time. The 10th improvement happened in RCT. You know, when I was an undergraduate student, just like you, a decade back, I would say whenever you have a root canal failure, even I used to remember my staff saying, if the root canal fails, it is going to go for extraction. There was nothing called a re-root canal treatment at that point of time, because endodontics hadn't improved that much in 2006-07 when I had done my internship. But right now in my clinical practice, almost 50% of the endodontic procedure which I perform is re-root canal treatment. Re-root canal treatment is a big chapter. It includes GP removal, it includes perforation repair, it includes ledge management, it includes calcified canal management, it includes separated instrument management, and many more. So it's a huge topic. Modern endodontics, that's a big change. We do re-root canal treatment and try to save the tooth, or I would say try to give the tooth a second chance to live or survive within the oral cavity. So if you look into the success rate of the re-root canal treatment, you can see it's not that bad. It's around 89 to 90%. So that means if you perform a re-root canal treatment well, the success rate is as high as 90%. Another improvement that happened in modern endodontics is periapical microsurgery. There's a huge difference between the conventional surgery and microsurgery. I would say in Kerala, conventional surgeries are done by a surgeon, whereas a microsurgery is done by an endodontist. I'm not undervaluing a surgeon. A surgeon is good in removing granulation tissue, but they are not good in doing something called retrograde prep, that is preparing the root canal from the tip of the root, and that is an important factor which determines the success rate of endodontics. And we do perform surgeries under the microscope. We give special sutures, we elevate special flaps, and the opening that you create into the root will be very small. We use special equipments to perform this retrograde filling. So that's a big change, or I would say a game changer for the last resort in saving the natural tooth within the oral cavity. So when you have a compromised tooth, we have two options. Number one is endodontic, perio, and restorative treatment, and the other option is extract and implant. So I would like to emphasize the importance of my specialty here, because if you look into endodontic implant algorithm, it's almost both have good success rate. Whether you do a root canal or a re-root canal treatment or an implant, if you have done it well, you get 90% success rate, both for implant and RCT. There is enough evidence to say that. But look at the contraindications of implant. There's a lot of contraindication for implant. It needs multiple surgeries, it is a little more expensive, and potential risk factors include systemic disease, genetic traits, smoking, periodontal disease, radiation therapy. There are a lot of risk factors for implant. But if you look the RCT or re-RCT, it's virtually painless. You don't do any surgery. It's mostly one visit, minimal risk. There's no risk factors associated with root canal treatment. So anytime you would try to preserve the tooth if it is possible. And this is one of my favorite statements, that is, there is nothing that will feel and perform like a natural tooth, because implant doesn't have a periodontal ligament. So till this time, we had discussed about the improvement that had happened in endodontics back in old days to the current time. Let's address few of the drawbacks of the current endodontics. That is, we hadn't improved in these aspects. Number one is diagnostic test. So if you look into the endodontics or the diagnostic test, which was done in 80s and 90s, you can ask the Devdathan sir what diagnostic test sir had performed when he was a postgraduate student back in early 90s or late 80s. He would definitely say, I had done heat test, EPT, and cold test. So basically, we do the thermal test and EPT at that time. Now, currently, if you ask a postgraduate student currently doing endodontics in Pushpagiri Dental College, they also say the same thing. That is, they do EPT and thermal test. So I would say it's a big lacuna. We hadn't improved much in the diagnostic aspects in endodontics. If you look into the previous, or I would say a decade back, you can see there are a lot of terminologies in diagnostic terms, like each one had given a classification. Wayne had given Engel, then Cohen, Grossman, Hartley. There are a lot of classification on pulpal and periapical diagnosis. But recently, AAE, or American Association of Endodontics, had come up with a diagnostic terminology. I want all of you to go through that. It's very simple to understand, so we follow this terminology as of now. Second, there's no improvement is the teaching and assessment. I would say there is no change in the type of questions. It's all direct questions, what we have had in 80s and right now. There's no change in the teaching style. There's no change in assessment or evaluation. There's no change in teacher-student ratio. So that's something that we have to look forward. We have to improve in all these four aspects which I had put up to improve the endodontics at this point of time. The third is the success rate. So if you look into the success rate of endodontics back in the 60s, 70s, and 80s, and the success rate right now, it's almost the same. So you may be thinking, in spite of all these advancements, why the success rate is not improving? The answer is quite simple. In 60s, a perforation, file fracture, complex anatomy, we advise extraction. But right now, we are doing everything. So obviously, we are taking up challenging cases, and that is exactly why the success rate remains the same. Don't think that we are doing a better work. We definitely are doing a better work in endodontics. So I'm not boring you guys with a lot of theories and other stuff. I hope you got a glimpse about the modern endodontics. Any further questions on endo or respiratory, I would be happy to help you. I would like to acknowledge my teacher, which I generally used to do after all my presentation. You can contact me in any of these platforms. There's a page called Root Canal Point at Facebook and Instagram. You can follow that. And there are a few presentations of mine like this short presentation, which is useful at YouTube. at Jojo Kotu. The name of the channel is Jojo Kotu. If you are free, if you are interested in the subject, please watch that. With this, I would like to conclude the presentation. Over to you, Bentley.
Yeah, thank you very much, Dr. Jojo Kotur, for the very concise and precise type of presentation about the endodontics long back and to the current situation. So I think students, if you do have any queries, please do post it so that we can take it up. Meanwhile, Dr. Jojo, you are doing a really good work by training the students, BD students and the PG students. So it is very great and good to see that many of the practitioners, the BD students and the MDS students are coming out in the best possible manner in endodontics with the recent advances. So that is something which is really good, because the training, I don't think very advanced training is there in endodontics, especially at the college level. So things has to grow up. Probably the DCI will modify the curriculum of BDS and MDS shortly. That is what we expect, and that should happen up. Okay.
You're expecting it for a very long time.
Yeah. What to do? Things has to come up for a change, but it has to start up at the DCI level. Yeah. But we are hoping things will come up. Yeah. So students, I think they have no queries. So Dr. Reno, I think you can give the proposed vote of thanks.
Okay, thank you, sir. So it's my privilege to propose vote of thanks. On behalf of Department of Public Health Dentistry, I take this opportunity to express my gratitude to our renowned speaker, Dr. Jojo Kotur, Professor, Department of Conservative Dentistry, Royal Dental College, Palakkad, for his excellent presentation. I think this is one of the best sessions we had. Thank you very much, sir. Now I would like to thank Dr. Billy George, Vice Principal and Head of the Department, for his constant support. Also, I express my gratitude to third years and final years, especially the coordinator, Steffi Sargent. Thank you all.
Yeah, so once again, I would like to thank Dr. Jojo Kotur. Thank you very much, Doctor, and all our participants. Thank you very much for sparing your valuable time. And Dr. Jojo, the memento and the certificate is already dispatched. Okay, so probably on Monday or Tuesday, you will receive it. It is already dispatched in the meantime. Okay, so thank you very much. Have a great day. Yeah.
Thank you. You too. Thank you.
Yeah. Thank you.
Thank you, sir.
Yeah.